Thank you. Okay, so I'll be talking about the basic technique of the glued IOL, the indications where we use it, the complications that we have experienced, and what has been our experience till now with glued IOL technique. As Dr. Gupta was pointing out, IOL implantation in the absence of a posterior capsular support, the options that we had till now were either we could use an iris fixated IOL such as an iris claw or an anterior chamber IOL, or a transcleral IOL fixation which could be done at the ciliary sulcus plane either with the help of sutures or by haptic externalization, what we traditionally call as glued IOL technique. Now, there were certain limitations when we used sutured scleral fixated IOL, limitations in terms of a lot of surgical expertise required. It used to take a long time. There were a lot of suture related issues such as suture induced astigmatism, suture degradation could happen, or rarely there were cases also of IOL dislocation or subluxation because one side of the suture broke or both sides of the sutures broke over time. So when we talk about glued IOL, there are three basic components of glued IOL surgery. The first being the 3-piece intraocular foldable lens that is used, the FIBRIN glue, and the basic technique or the surgical technique of doing the glued IOL. The IOL that is typically which is used by us is a 3-piece foldable intraocular lens. It can either be the Alcon MA60 variant wherein you have a Prolene haptic with a J-loop haptic with a hydrophobic center, or the C-shaped haptics in cases of such a Technis 3 lens. These 3-piece lenses allow for a lot of flexibility at the IOL haptic optic junction, allowing them to be externalized much more easier compared to the more rigid single or more rigid PMMA lenses. The FIBRIN glue consists of two parts, the human thrombin and the human fibrinogen, along with the activator, the aprotonin. The thrombin breaks down fibrinogen into monomers and then fibrin polymers, which acts as a good adhesive and holds the IOL haptics in its place. Sorry. Now coming to the technique of the glued IOL. The first step basically involves making two 3 mm by 3 mm scleral flaps on either side at 3 and 9 o'clock position and a superior scleral tunnel for the IOL insertion. Subsequently, you start off with your anterior segment procedure, the clearing up of the anterior segment, as in this case was a Marfan's patient. You're doing a lensectomy to clear up the subluxated lens. Then you insert the IOL, make an opening about 2 mm from the limbus under the flap. Use an end grasping forceps to grasp the tip of the haptic. It's important to grasp the tip there and slowly insert the IOL into the anterior chamber and grasp the haptic and take it out through the incision. Then do the same procedure on the other side, get the haptic out on the other side. Once both the haptics are out, we take a 26 gauge needle, make a groove on the edge of the flap into the sclera. And in this groove, as you can see in this animation, we make a groove on one side. We're making in this video. And in this groove, then we tuck in our haptics on either side. Subsequently, the FIBRIN glue is applied, both the components, and the flap is closed over it. Before the glue is applied, it is completely dried off so that the glue can work nicely, only in a dry surface. Tucking the haptic in those grooves gives you a very good stability. It does not allow forward or backward movement of the haptic. It also does not allow up and down movement of the haptic, providing a very well-centered and a stable IOL in its place. So the advantages of glued IOL, it provides you with a technique which gives you a IOL which has minimal phacodonesis. There's a better centration. There is hardly any tilt. There are no suture-related complications such as ciliary body rubbing, suture erosion, knot exposure. Takes much less time. Even the same IOL, if there is already an IOL which is subluxated, we can refixate the same IOL. You don't need separate special kind of IOL such as those SFIL with eyelid that used to come. So you don't need any special IOLs for this procedure. So what indications we are using it? We are using it for a variety of indications. Using it for traumatic cataract with subluxated lenses, traumatic aphakia following complicated cataract surgeries, Marfan's patient, subluxated dislocated IOLs, aniridia with cataracted subluxated lens, and so on and so forth, wherein we find that posterior capsular support is not going to be enough to support an IOL. wherein this IOL procedure can be safely carried out. Another advantage, it's quite a flexible procedure. A lot of modifications can be done to the procedure and allows for us, we can use the same technique using a small incision with an injector. You can inject using an injector, grasp the tip of the haptic, slowly unfold the IOL into the anterior chamber, and then take the haptic out. So you don't even need to enlarge the incision size to a 6 mm. You can do it through a clear corneal small incision. You can fixate a subluxated, or in this case a dislocated IOL. We are using a chandelier here to visualize the IOL, grasp it, bring it up, and then straight away externalize and fixate it. So a lot of flexibility and possible with glued IOL technology. Yes, there are complications. There are intraoperative complications such as trauma to the iris, iridodialysis, hyphema, vitreous hemorrhage, postoperative issues such as IOP dislocation, exposed haptic, CME, and persistent uveitis. In our experience, what we have seen over the last 5-6 years, out of the total number of eyes that we have operated, we have analyzed the data of about 458 eyes with a follow-up of 6 months to 3 years. Most of the cases that we did were of subluxated IOLs, about 50% of them, and the rest other indication from the remaining 50% of the cases. And what we found out that the mean post-operative best corrected visual acuity was as good as 0.56. Vision better than 20/40 seen in about 80% of the eyes. That's quite a good number of patients. These are some of our cases which have shown excellent result. Patient with Marfan syndrome, patient with anteriorly placed IOL which was refixated back behind the iris, some other patients who had amazingly good result following glued IOL. We had our share of complications, but what is important to know is all these complications tend to happen more often in our initial cases. As you keep learning, keep improving, your technique becomes finer. The complications such as haptic bend, break on externalization, they all tend to go down with your surgical experience. Rare complications, 1-2 cases we had where the scleral flap melted. These were small eyes with twice operated before the conjunctiva retracted, leaving behind a bare sclera and the flap melted, in which we had to subsequently do an amniotic membrane graft over and a scleral patch graft over the IOL. But we did not need to explant the IOL in these situations also. So in conclusion, fibrin glue fixation is a safe and effective alternative to suture fixation. It's a very easily and a successfully adopted technique, reduces surgical time, improve patient comfort, stable IOL, no tilt. You don't need anything special IOLs for this, and this can further be expanded into use of multifocals and even anaridic IOLs. Thank you.